Correct. Actually, remember when
Perfect timing.
yes.
Perfect timing. Thank you. It is 7 o'clock p.m. and I would like to call the meeting of the Health Hospitals and Social Services Committee to order on tonight, Wednesday, January 14th, 2026 AD. So we have a number of uh, esteemed individuals in our presence tonight. And so I'd like to start off with, again, a welcome and an introduction of the committee members and guests as per our agenda. And so let's start off with a roll call.
Uh, Dr. Wayne Beeson,
Present.
Sebastian, I'm not gonna butcher your name on the
It
record.
is Sebastian Chitlapilli.
Titlapilli,
Yes, that's it.
Dr. Julia Gomez, the rabbi is, that's not the rabbi, and Steve Matthews.
Here.
We have quorum.
Okay, it's Rabbi outside.
I don't think that was.
No. All right, so that being said, we have quorum. First of all, again, welcome everyone to the meeting. I think we are honored to have State Senator Gustavo Rivera present with us remotely, as well as Flavia Salazar, who has been a fantastic coordinator through multiple emails and phone calls. And we have a number of other invited guests. We have pleased to have Ms. Rabner here again, as well as Maria Teresa. And so the next item of business is approval of the meeting minutes from December 10th, 2021. Has everyone had an opportunity to review the minutes?
Yes.
Okay, move to approve.
Second.
Are there any abstentions? All right, all those in favor? None opposed. The minutes of the meeting passed. Next on the agenda, we are pleased to have State Senator Gustavo Rivera, who is the chair of the Committee of Health. And I believe, Senator Rivera, you're going to be speaking to us today on some of the New York Health Act, and as well as any other topics of interest regarding health and hospitals and social services. And I cede the floor to you at this moment. Do you need control of the Zoom?
Not really. I mean, I would really love to know is there somebody that's editing in real time? Because it's like it kind of splits and then it just like sometimes it goes into like it looks like there's an actual director like making sure that the things change. Is that like
It's
are we in the
these
future?
owl cameras.
It's called an owl camera. It's sort of a multi-directional speaker and camera system, and I guess
Yeah.
it tracks motion. So for better or for worse, no one's it's
Over here, it looked
artificial.
like there was an actual like editor like cutting away because when you did the vote and then one of the members that I can't see really on the top on that long screen that's like the 360 view, then all of a sudden they were right on screen and I was like, wait a minute, there's like split screen. It's like anyway, it's just I was impressed. I was like, I didn't know that we had this technology in like community board meetings. I mean, like, God bless America. Um, so good evening to all of you, and thank you for giving me an opportunity to be with you this evening, and thank you for giving me the flexibility to do it virtually. Certainly, the first of all, Wayne DeBeetham. I want to make sure that is that the way that
Correct.
pronounced it correctly? All right.
Yes,
So
yes.
thank you, Chair Dr. DeBeetham for the invitation. So I'll do I guess what I'll do is I do a top line of just describing what the New York Health Act is, why I think
Hello.
it's necessary, kind of give the oh, somebody just jumped in. So
Oh, no, I
welcome.
just want to make sure I'm muted. Can you hear me?
We you are not muted.
Okay, then I will mute myself. Thank you.
No worries. So I'll give kind of a top line of what the New York Health Act is, why I believe it's necessary, and then certainly open it up to questions because usually it flows best when it's kind of a back and forth conversation because I'm sure that folks either have questions already or will have it when I do my brief thing here. So I believe that healthcare is a human right. So I believe that how wealthy you are should not be the determining factor on whether you get healthcare or not. The reality is that the US does indeed have the best healthcare system if you can afford it. Uh, the the way that the current system is organized and functions is one in which if you have money in your pocket and you can pay out of pocket for whatever it is, as if though it were a luxury, you'll be fine. But the overwhelming majority of Americans, and by this I mean not talking necessarily about the uninsured folks, which is a population that certainly is there, but we're talking about the folks who have insurance, right? The idea that we have that is overwhelmingly in our people's heads that has been baked in there, I believe, by insurance companies for generations now is that to get good healthcare, you need to have a good insurance product, right? The idea that, you have two jobs to choose from, and I'll choose this job as opposed to this one because they have better healthcare over here. Or if you're in a bad relationship and you can't really stand your spouse, but if I leave, I won't have that healthcare. That just get the guarantee of an insurance company of insurance product doesn't actually guarantee you healthcare. It guarantees you an insurance product. It guarantees that you have a little card in your pocket, but it does not guarantee you care. And one very important thing that we need to underline is that this is literally the only modern democracy in which you can go broke because you get sick. It is an obscenity to think that this is a reality in American life every single day. And so the question is, what do we do about it? Well, there is a solution. And the fact is that it is not something that it is not some science fiction fantasy that exists somewhere out there right next to the Loch Ness Monster and unicorns. Instead, there is a version of this that exists in every single modern democracy in the world. And that is having a single payer system. Now, what does that mean? Right now, we have what could be called what we could call a multi-payer system, which means the provider, so the doctor, hospital, etc., can get paid from a lot of different places. They can get paid from an insurance company, they get paid from Medicare, they get paid from your pocket, etc., etc. It's a multi-payer system. Single payer system means that one place is the one that actually pays the bills, and in this case, would be the state. And what happens there is that there is a guarantee of health care for every single New Yorker. And the bill that I have called the New York Health Act would create such a system. And it would ultimately mean that you would have every person who is a resident of the state of New York, regardless of their age, of their wealth, of their immigration status, if they're either residents of the state of New York or are full-time employed in the state of New York, would be eligible to be part of the New York Health Act system. Now, you would think, like, how does this actually work? Like, how would you create a system? How does a system in which you would not have premiums, no copays, no networks, no deductibles, how is that even possible? Well, the current system that we have in the United States per capita is the most expensive healthcare system in the entire world. But the reason it does not give us better results is because there's a huge chunk of it that is not dedicated to actually providing you or your family or any American actual health coverage. Right now, if you think about the fact that between 15 and 18 cents out of every dollar that go to a private insurance company goes to administrative costs, that is not only profit, that is also CEO salaries, as well as a whole apparatus of people whose job it is to make sure that you don't get care. Insurance companies don't make money by providing you care. They make money by denying you care. That is a business model. So if we go from a system in which we have 15 to 18 cents out of every dollar go to administrative costs, because you still need to run the system, how about we go to a system in which you pay 3 to 6 cents out of every dollar, like Medicare or the VA? That's one way you save money. Second, you provide a guarantee primary care to everybody. Right now, you have there's some people who use the emergency room as primary care because they don't have any other way to get any type of care, right? By guaranteeing primary care to everybody, not only do you provide better, like life is better for people because they can be identifying chronic conditions earlier, they can focus on wellness as opposed to that pain that they've had in their stomach for the last 5 weeks that they can't get rid of. So instead, we do that. We provide not only a better life to people and a better experience to people, but also makes the system cheaper, because when you don't have people who use emergency rooms for primary care or people who focus on wellness and not on sick care, it makes the system cheaper as a whole. Number three, you guarantee, you as a state, we can actually negotiate with pharmaceutical companies for better prices for for drugs. So if we do that, if we say as a state, we want to negotiate on behalf of the entire state of New York with this pharmaceutical company, do you think we'd get a better price on drugs if we did that? And the answer is yes. So if you take all of those things together, and the fact is that you take the entire state of New York, so you have both high-end users, low-end users, and everybody, and cover them in one system, you would have a system where you actually spend a lot less money and actually provides better care, because it is not focused. Profit is not the focus. Instead, the focus is the benefit of patients. And this will be a system, by the way, that will cover everybody, meaning me, you, and every single New Yorker. So you would have something that would cover everybody, would exclude no one. And therefore, even if you have people who are running, the people who are running the system, the board that would be created to run the system would actually be covered with it themselves. And one last thing before I pass it back on to you, one of the things that you can think about is the fact that right now there's so many people who are consistently making decisions about their healthcare that have nothing to do with their healthcare and have everything to do with their finances. Unless we go towards a system as a single payer system, that is going to continue to be the case. This has been this way for a very long time. The fact that we accept it as a given that we can go broke because we get sick is an obscenity. We can go in a different direction. Don't let anybody tell you otherwise. We have the ability to do it in the state of New York, and I believe that we have an obligation to do it in the state of New York. We're far ahead of other states. I'm actually working with a coalition of elected officials from state legislators from like 7 or 8 different states that have either introduced bills or are about to, et cetera. And we're going to do some work in this year to kind of like bring this up in a more make it more central piece of the political conversation. Because the reality is, if we're going to talk about affordability, the fact is that healthcare is at the center of people's inability to be able to afford their lives. So I have this bill. I introduced it. I've been a sponsor of it since 2017. But I'm going to be doing a lot of work this year to actually bring it up more, to actually to push the volume up on it. And conversations like this are an important piece of it. So with that, I will say thank you for giving me, having given me the opportunity to be with you for this time, and I'm willing to answer any questions you might like. Hopefully that was not too long.
Thank you, Senator Rivera, for that very interesting discussion. And I think one of the topics that I think all of us who I think one of the blessings that we have in this committee, I think, is that everyone is involved in healthcare in some way or shape or form. And even for those who aren't, if you're human, you've seen the healthcare system at some point in time. So I think that it's a timely discussion, and it's an important topic. And I think, again, I would love for anybody here to at least start the questions.
Senator, would this replace all current employer-funded insurance? And
That
what
is
about
correct.
Medicare and what about Medicare and Medicaid?
This would basically basically be the one thing that is provided by. So the way that it would work is because funding is tied to it. We take Medicare and Medicaid funding, right? The thing that like Medicare and Medicaid already paid for a whole bunch of things. They will continue to pay for those things, but then we would take a graduated tax, so a payroll tax based on ability to pay. We would throw that into the pot as well, and that would pay for the rest of the services for everybody else. So it would the thing is, it would replace it, but it wouldn't push it aside. It would be an addition to. So I don't want to be like, I don't want to lose my Medicare. It's like you wouldn't be losing your Medicare. You won't be having to deal with your Part D situation. And you will also have you will have a program in which anything that is medically necessary, including dental and long-term care, all of those things would be services that would be covered by it. So if you're Medicaid eligible or you're Medicare eligible, or you're dual eligible, like you would receive all the services that you receive now, and then on top of that, a whole host of things that won't cost you any more money.
So would it replace Medicare supplement? Or function as a Medicare supplement
It would
program?
it would function as its own thing, but it would be like whatever the services that you're receiving from Medicare now, it would not push them to the side. It would be added. They would have additional services applied to it. Like, for example, you don't
So
have
if you-
long-term care as go ahead. I'm
Okay,
sorry.
so it would be an additional, couple of additional benefits to
Not a couple,
traditional.
not a couple, a whole bunch.
Okay, but right now, you can be on original Medicare, which covers everything that is approved, with co-pays and deductibles, depending upon.
Mhm.
You can then purchase a Medicare supplement plan that will cover part or all, depending upon how much you're willing to pay for the supplement plan, of what Medicare does not cover. That does not include dental and
Long-term care,
those types
drugs.
of
Yeah.
long-term care. You can also purchase a Part D plan, which will cover drugs, and that you have a choice of a number of plans. So how does this fit in for those like me, who have traditional
not need to-
Medicare supplement?
You would not need to purchase any of those supplements. You would not need to purchase the drug plan. You would not need to purchase a separate long-term care insurance. You would not need to purchase a dental plan. It would be covered if you're a resident of the state of New York and you are and you will continue to live here, you will be covered. Period.
So. Rebecca?
No, actually, I had the same question about the supplement. And from my understanding is that this would be all supplemented, or this would all be available.
Oh, I hadn't seen you,
Uh,
Rabbi. How you doing? I didn't because I can't
Good.
in the big screen. I couldn't tell who was like the person all the way in the back was like, yes, how you doing, sir?
Good to see you. This would be something that would be paid for by, as you said, I graduated, sorry, let me just.
A payroll tax. So Medicare,
graduated tax, yeah.
Medicaid, a payroll tax, and taxes on. Hold on a second. The second thing is there's like some taxes on investments. Give me 1 second. What's that second one? But it's payroll tax is the most is the bigger piece.
Okay, thank you.
So in I'm sorry, go ahead.
Just a question, if I am an employer, I have no choice, I have to pay into this single payer.
If
But
you're an
if I-
employer, do you provide healthcare to your employees right now?
No, I'm not talking about myself, but I'm just
Okay.
saying, for an employer.
Yeah.
There is no option, you have to pay into this single payer system. And there's no option to use those funds to buy some other insurance, you have to take this insurance.
No, you're not paying. This is the most important piece here is that you're not paying for an insurance product. That is not what is happening. We are not supplanting with another insurance product. We're providing you a plan that would just cover this stuff. And it would be if you as an employer, the language in the bill currently states that of the payroll tax, and the payroll tax is based on ability to pay. The first $25,000, if you're a retiree, your first $50,000 of income are exempt. If you are not a retiree, the first $25,000 are exempt. But after that, there would be a graduated assessment, so a payroll tax based on ability to pay. And that would be the current language in the bill says that the employer has to pay 80% of that minimum, and the employee pays 20% of it maximum. That can be negotiated so that in some instances, for example, public sector workers that have already negotiated so that they don't pay any of that tax, there would actually be a continuation, so they wouldn't pay anything coming into the new system. But because it's everybody putting it into the same system, it would actually be much less than what any employer pays right now to provide healthcare for their members, for their employees. So the short answer is yes, you would pay the payroll tax, but the payroll tax is going to be less by a lot than whatever you would pay for a healthcare plan for individuals who work for you.
So if there is a need to buy a healthcare plan,
You wouldn't have a need.
then
It's
but what if the formulary doesn't cover the drug that people need? Then the board doesn't approve the formulary, and that there's a new drug. It's not on the formulary. The entire state cannot get it. Somebody needs it, and they have this is something happening in countries like UK, right? They don't cover a lot of drugs.
Okay. In the case of the UK, by the way, one of the most basic differences between the National Health Plan in the UK and the one that I'm proposing is that this would not be the providers would not be employees of the state, right? In the case of the National Health Plan, all like doctors, nurses, etc., like there's a bunch of them that are part of the National Health Plan. They are employees of the National Health Plan. They're employees of the UK, right? This is not what we're proposing here. Providers would remain individuals, right? And as far as formularies, as far as what like the decisions about what drugs are included or not included are determined by the board. The makeup of the board, I can give you the bill. There's like the board is like 30 some odd folks, but it includes physicians and nurses and hospitals and unions. There's a whole bunch of that board would make a determination on what drugs are included and what drugs are not included. If the argument is if something is medically necessary and the determination has been made there, then it would be included as part of the program. Now, I can't tell you there's obviously new drugs being developed all the time. There's new treatments being developed all the time, and it would be the job of that board to maintain themselves on top of it. But this is the thing that you have to consider. The decisions that are consistently made right now by insurance companies about formularies, about networks, etc., have nothing to do with your well-being. Not a thing. It has to do with their bottom line. You might have a doctor that you have been going to, that you've been taking your kid to for 10 years, 15 years, 20 years. And then the insurance company decides overnight, for no reason at all, that person is no longer on the network. You're screwed. Remember what happened a couple of years ago when United Healthcare all of a sudden decided that Monty was no longer going to be a covered entity. So all of a sudden you had thousands of Bronxites who rely on their healthcare for the institution that they have next to them, and they all have United Healthcare, and they couldn't go because the decision was made by the insurance companies, not because of anything except that they wanted to make more money, so they had to pressure the system and to do more. Because you have at the center of this system right now, what you have as the driving force of it is profit. The decisions that are being made about formularies, about networks, etc., that are made by insurance companies without any input from you as a patient, without any input from us as legislators, and strictly inside their offices around their bottom line, this would be a system that would be far more transparent than that, because it would be a board that is a public system, and one, by the way, that covers you, your children, and me, and the governor, and everybody in between. So part of having this idea of having everybody in and nobody out means that part of the decisions about making sure that for example, if there's a drug, if there's a treatment that is necessary, so that is something that's medically necessary that would actually cure a disease or something, then part of having all of us be covered by that means that I would be part of the people that would be speaking to the board and being like, this is something that you need to consider as one of the treatments that needs to be included as part of what is covered in the program. See what I'm saying? It's a completely different way to think about how the healthcare is actually delivered.
What would be the network or networks?
One, the state. That's it.
Everybody. So
All hospitals in the state would be required to accept it, and all primary care and specialist physicians would be required to accept it as a condition of their license?
Well, basically would be the only game in town. And by the way, as far as the payment structure, there's something else in there that's important to point out. The rates to be paid have not been determined by statute. But there is statutory language that says that the rates to be set have to correspond to the cost of care. Let's think about that for a second. So you have a system right now, Medicaid, for example. Medicaid rates are garbage. If there are providers in the room, I don't have to tell you. You know this to be true. And that means that institutions that serve a lot of Medicaid patients basically lose money every time somebody walks in the door, which is one of the reasons why they constantly have to make decisions about how do we make it so that more private payers come in here so we can balance out the fact that we're losing money every time that we treat someone who is underinsured or whatever. So if we create a system that by statute has rates to be set that have to correspond to the cost of care, you will immediately have maybe not private payer level, but it won't be Medicaid level. There's Medicaid here, there's Medicare here, there's private here. How about if we set it right here? Places like St. Barnabas, all of the public hospitals, all of a sudden we'll see a rise in revenue. And a lot of physicians who currently don't take Medicaid patients because they don't want to deal with being paid so little for whatever they have to do to be with patients would actually we create an incentive that would put them in a situation where this is the way to go. It pays better, it covers everything, and you get one check from one place. You don't have to be fighting with people about what is prior authorization, whether, oh, we're not going to, I'm looking in my screen and saying that this is not something that's covered. And I'm like, what are you talking about? I am the doctor. Like I'm sure that you've seen the videos, and if there's providers in the room, I am sure that you either have stories or know of stories of you, the physician, making a determination about what is necessary for your patient, being ready to provide the thing, and then being told by an insurance company, not covered. I'm like, why not? This person needs this. They need this drug, they need this procedure, they need this. And so at the core of this whole thing, and I understand that it's a kind of it is because we have been so ingrained for generations to think that the only thing that works is getting an insurance product. And then that's the best that we can do. The notion that we would create a system that pays better, that is simpler, because it is far simpler to have a single payer system than have a multi-payer one, to have one that pays better, that is a single system that does not, and as far as the patient itself, at the point of contact of care, no premiums, co-pays, networks, deductibles. That is possible. It can be done, and if we do it, we will actually save money because it won't have profit at the core of it.
I have a question regarding portability of product. So let's say a patient has an accident or sees a surgeon or physician in, say, New Jersey or Connecticut. How does that then go across state lines?
The way that it works,
well,
the way that it works right now is if you have, it's in that sense, it would work kind of like an insurance product, but instead your providers, like if you, God forbid, have a car accident in Jersey, if there's an emergency, you will be treated for that. You will be treated for that, for whatever physical ailment you have, and then the payment will be sought from the state of New York as if though it were your insurance company. So that is there you go. And as far as you residing in a place like New Jersey or Pennsylvania or Connecticut, if you are, the way that the bill is currently written, if you are full-time employed in the state of New York, paid by a company that is New York State company and are employee of the state of New York, you are eligible to be part of the program. And in that case, it would be basically providers in Jersey or in Pennsylvania or in Connecticut, in the same way that they would make a determination about what, much like they do right now, like, oh, we don't take this insurance, but we do take this insurance. Do we take the New York Health Plan? And if we take the New York Health Plan, and the thing is that, think about the situation in which you have one plan for an entire state that is well-funded and pays better. The notion that they would not take it is hard to, like, just if you look at it as a rational choice type of situation, they would accept it. So, but the way that it works again is if you have a situation, an emergency situation, someplace else, they would the same thing that would happen now is what would happen then, except that as opposed to going to, Aetna or Empire or whatever, it would be the New York Health Plan.
I have a question. Like, you told that this will have Medicare and Medicaid into the system, right? The money for Medicaid and Medicare will stay in the system. However, there are eligibility requirements for Medicaid and Medicare, right? How do we make sure that those dollars does not go to the people who are not, for example, Medicare dollars stay with the Medicare eligible patients and does not get distributed to others.
Very good question. So if we have if we have a there's something called a waiver. The when we if we go to as folks know, Medicaid, for example, Medicaid is a program that is about 50-50 federal dollars and state dollars, a state share and federal share. And we go to the state, we as a state, any state can go to the federal government and said, hey, could we use the federal share of a program of the Medicaid dollars that you're sending us to do X, Y, or Z? If they say yes, they give us a waiver and we can do that. We have more waivers than any other state in the country. If we had a waiver from the federal government, there would be no problem whatsoever, and we would be able to use Medicare and Medicaid money the way that waiver would determine. If we are not able to do that, and I will be honest, obviously having this administration in Washington D.C., the likelihood of a waiver is almost non-existent. What we could do then is as long as we would have less savings, by the way, there's an analysis that tells us that the savings would be somewhere in the neighborhood of about $55 billion of savings. $55 billion of savings that we could achieve by going to a system like this. And it wasn't I that said it, it was the Rand Corporation in an analysis a couple of years old. But regardless, if we don't get a waiver, then the savings would be less. The reason for it would be because we would have to create a system in which we would track exactly what you're saying, to make sure that every eligible dollar only goes to eligible costs, so that if we can track it, if we can say to the federal government, this dollar that you sent us has only been used in eligible costs and eligible things that you have already approved, or not only that you've already approved, but that every other state uses it for those reasons. If we can track that, if we have a system in the back end, it does not impact the patient or the provider. It is on the side of the administrative side. We just have to make sure that we track every single one of those dollars, and that can be done in the back end. See what I'm saying?
So let me follow up with that before I ask that question. With the tracking of the dollars, well, let me do that first, actually. I'm glad you named the 1,200-pound gorilla, the administration of Washington D.C. right now. One of their narratives, and I'll politely call it a narrative, is that there's all this money going towards undocumented, they use other words, undocumented immigrants or undocumented people in certain circumstances. For instance, I sit on the board of an FQHC, and under the rules of an FQHC, no one who's not documented can be paid under those kinds of dollars, anything federal dollars. However, if this is a state plan, how do you ensure that those who are using that narrative are going to be assured that those dollars are not somehow becoming fungible?
We can't. Well, first of all, it's the argument, or the narrative, as you call it, that we're providing services to immigrants, to undocumented folks by using federal dollars, is just a straight lie. That's not happening. We can't do it. And you know that to be true. So you know that they're going to keep lying. There's going to be lies and lies and lies on top of lies on top of lies. The only thing that we can do is to create a system whereby we can track, like in the case of like it'll be like we would just create a system again in which we can track $1 that comes from the state and has only from the feds. We can use, by the way, we can use state dollars for whatever we want. All right. So we can use state dollars for whatever we want, but the federal share needs to be tracked. And that would, as long as we create that system in the back end, that would be like, are they going to try to question that and try to call that a fraud? Well, of course they are. This is what they're doing right now. We can't avert them trying to lie themselves into thinking that our entire system is being destroyed by people who are dangerous. This is what they're doing right this second. We can't stop them from doing that. I mean, we can try to unelect them, certainly. We can fight against that narrative publicly. We can organize against it. We can do all those things. But as it relates to this, they're going to lie about it. They're lying about everything. They're going to lie about this. What I can tell you is that there is a way technically to create, and it is not a difficult thing, but it does take more resources So if we create an administrative apparatus, that part of the job of that administrative apparatus is to track such dollars, and we already have services, by the way, that we use as wraparounds that we have in the state of New York, that we actually do something similar already. But it would not be as not it's not as broad, it's not as, statewide. It doesn't cover that many people, so it would have to be a bigger system that would take more resources and therefore would cut a little bit into our savings. But the bottom line is that I am convinced that it can be done without a federal waiver. Now, let me be clear. There is a bill, not to, let's dream for a second, shall we? There is a bill that was introduced by Ro Khanna in the House, and from Massachusetts. I forget the name, but the Senator Markey, I believe, from Massachusetts. I'm pretty sure that's the guy. But they introduced
Yeah.
the bill in the U.S. Congress just in the middle of last year. I actually went down to D.C. for the unveiling of this bill. If that bill were to pass and be signed into law, if any state that passes a single payer system would automatically get a waiver. So there are people at the state in the national level that are thinking about how to do that potentially. But I'm not only assuming that we're going to have that this is the administration that we're going to have for a while, that an administration that is as mendacious and as authoritarian and I'm assuming all these things, but I'm saying that precisely because this administration is so terrible and because the attacks that they're having on people are directly let's look at what they're doing to healthcare and how much more it's going to cost us and how many people are going to get sick and die because of the actions that they're taking there. It is the moment to take bold action. If there was a moment to take bold action, it is now. And what is the worst that we have to lose? That's the thing. It's like this is why I'm so damn passionate about this, because not only is there basically, as I said again, and by the way, one thing that I need to underline here, I am not claiming that this is going to be perfect, that any system built by humans is not perfect. But the notion that we can build a system where nobody can go broke because they get sick is an absolute reality. And if that is the only thing that we achieve, and I know that we can achieve much more, but if we can achieve a system in which we can guarantee that nobody goes broke because they get sick, that's the hill I will die on. So just wanted to.
One additional question, and I've never quite figured this out. What happens to the existing system? So for instance, there's Health First and there's always.
Yep.
Delivery.
So,
insurance
the bill would
companies here.
Yeah, the bill would create a transition board that is different from the board that runs the system. The way that we envision it is that it will be a 3-year transition period. So a board would be created for the purpose of transitioning the system, creating the regulations and the site. And while the regulations are being created and the battles are happening about how the system is going to be actually shaped before the switch is flipped. So basically, let's say hypothetically that we had passed this bill 3 years ago. We had been doing the work that we needed to do for 3 years to kind of set up the system. And in December 31st of last year, we turned off the switch and we flipped on in January 1st. That means that anything that was done before December 31st would still operate in exactly the same way. So the battles that there would be leftovers, because obviously there's still procedures that would have been performed and people that have to fight insurance companies to do whatever it is that they got to do. But then after January 1st, any services that are provided going forward would be paid by this new system. But again, it would be a transition board, the makeup of which is in the bill. So I can actually obviously share that with you, and you could I forget the section it's in, but it's obviously a public document. You can see it. But it would be, we envision a 3-year period where the process would be that transition.
What happens to all those employees of all those companies that are now operating in the thousands of people, where they have pensions or they have other kinds of benefits coming to them? Who would allow them to remain safe?
Couple of things. If we're talking about, I don't know the exact number, and I think that some of the numbers that have been shared might have been a little bit exaggerated, but I will acknowledge that there will be some folks who will whose jobs will no longer be necessary in this new system. There's that is accurate. I'm not going to deny that. But a couple of things. Number one, there is language in the bill. First of all, there are a number of them whose skills would be necessary to actually run the new system. So there's a likelihood that there's some of these folks that we would actively seek out to actually transition over to actually become public sector workers to run the system. That's number one. Number two, there is language in the bill that both relates to training as well as extra money for unemployment for whomever the folks are doing between that lose their jobs because of the transition. And number three, very, very importantly, regardless of how many folks actually are in the process of looking for another gig, every single one of them will have health care because they don't need it. The job is no longer tied to whether they have the healthcare coverage or not. So there is, and we work with that, by the way, some of that language we worked on. I was 1199 actually that has had in its existence has had many times when there's this transition from one, technological achievements have made it so that certain jobs have had to fade away while others get up. There's new skills that have to be transferred to new people, new machines that they have to work with, etc. So we work with them to actually get some language for, again, training, have some extra money for unemployment benefits for those folks, and underlining again, whomever is looking for a gig will do so with health coverage already because they're just residents of the state.
Just one question regarding the residents of the state.
Yes, sir.
What if you have kids who go out of state for school and stuff like that? Right now, they can be covered until they are 26, right?
Mm-hmm.
On your
If they would-
parents' insurance. They will lose residency, right?
They will lose residency, but if if they're part of your family, there's going to be they will be covered until a particular age. I actually will get back to you on that, but I know that there's a part of it that there's language in the bill that relates to the like being a family resident period is regardless of age, but that if someone is a family member and is not permanently away and is beyond a certain, I think it works similarly as far as like 26. If they're a family member, that they still will be covered by basically your plan. But I'll have to get back to you. Flavia, make sure I talk to Tony about that, and we can get the gentleman's name, and we'll get it to the whole committee. But that's I have a good question. I will track that down for you.
Can we get a full copy of the bill on the
Absolutely.
State Senate website, or
Yes,
should we
yes, sir.
contact your office?
Matter of fact, Flavia, could you put the link on the Zoom right there so that whomever is operating, if you're
I can't comment.
We're in chat.
you can't comment.
No,
Okay,
just-
so I will send you. Flavia will
I'll email
before-
you.
right before the end of the night. We'll email you a link to the bill so you can get the whole thing.
Does it have an S number?
Yes, it does.
What is it?
I don't remember. It's 56 something. Hold on.
It's S3425.
3425.
Okay.
2-5. That's all we needed.
Personally, I'm a big fan. One thing that I think, one layer of this I don't think we've touched on explicitly is, as a social worker, the way the mental health relief that this could potentially create, in that, God forbid, a loved one gets a cancer diagnosis. In the middle of fighting that, you still have to figure out how you're going to pay for it. And that takes this away. You don't have to worry about finding someone to deal with your depression and your anxiety, because that's all covered. My question for you, Senator, is
Yep.
just out of curiosity, what's the biggest point of pushback you're getting, or the biggest naysay, like this isn't going to work because?
So there's a couple. I think that a big underlying one of the biggest underlying hurdles is the notion, as I stated more than once, it has been baked into our heads that the only way that a system works right now, that the only thing that's feasible, as shitty as it is the current system. That what we're talking about is kind of like that just sounds like crazy commie nonsense. Like that's one of the, it's like an underlying thing that people feel that I just need to get a good product. Like, for example, I had a whole debate. The guy who just he was the guy who ran Northwell. Northwell is the biggest healthcare system in the state, and the guy who just left.
Michael Dowling.
Michael Dowling. So I remember the first time that I actually sat down with him, we had it was great because it was like my committee director, me, one of his people, and him we went out to Long Island and we sat around the table for like 2 hours drinking coffee and having a debate. And about half an hour was just like, let me get to know you. And a half and a half was a single payer. And he's Irish, by the way, from Ireland. And so we were talking about single payer, and ultimately what he told me is like, I acknowledge everything that you're saying about the current system, but I know this system, so I can manage it. So I would rather do this than the unknown. And that's kind of an underlying thing. There's always the notion that I'm trying to actively destroy the business model of insurance companies. I am very open about that. I think it's an obscenity that people are making money off of making sure to deny you care. And so there's obviously a lot of interested parties there that certainly are doing everything that they can to to sow dissension, to try to make sure that the bill does not move forward. But I got to tell you, the one thing that has been mostly that's particularly heartbreaking to me is that the reason why this hasn't gained more momentum in the state of New York is because of some public sector unions, in particular, say downstate DC 37, to a certain extent UFT, and then CSCA upstate, and some of the pushback from them is very similar to the whole notion about like it's like the bird in the hand problem. They're like, well, we have this that we fought for years. We've given up so much, we've given up so much over the years to have this thing that we have right here. And it's an insurance product, yes, but it's better than most of the other insurance products that you can get, which is accurate, right? But still an insurance product. So they're saying, you're telling me that I got to let this go. And that's a difficult thing to get them to do. So there's also concerned about the benefits. They're concerned about how much they would pay, etc. Things that we have addressed in the bill, by the way. But then there are some folks who are not necessarily good faith actors. And there's been misinformation about what the bill does and how it does it. And I'm working through that. But if we can get any of these three public sector unions to come on board, because there's a whole bunch of unions that are supportive of it, 1199, the nurses, CIR, SEIU, RWDSU, CWA, et cetera, et cetera. So there's a bunch of unions that are supportive, but there's some public sector unions who are resistant, and that has been difficult to break through. But I am nothing if not dogged. So this is something that I believe in deeply, and I will continue to do the work to get them to a better place.
So full disclosure, Northwell employs me, but
Yeah.
but
Listen,
I think one of the-
I had no beef with the dude. It's just it ultimately, it's like I get what he's saying. I think it's short-sighted, because ultimately what he acknowledged is, the system is fucked. Pardon my French. It's screwed. It's screwy. It's like it doesn't. But I've learned how to finagle it, right? And so he figures if he knows how to finagle it, he knows how to do that for his patients, then that's the best that we can get.
Well, they actually tried to have their own
They
system
did.
for a while and it
It
failed.
failed miserably.
Yeah.
But I think one of the concerns is, I mean, we are starting to see health systems that are spreading across state lines. Northwell, which just acquired New Vans, and so now I guess one of the questions is, since your paycheck technically now comes from New York State, but you will now have physicians in hospitals and people who are living well outside of New York State, who may never even set foot in the state. How does this product? I mean, like you stated before, I'm assuming it would be much like if you said you had Cigna or Aetna, you can basically say, well, this is my insurance. But
I gotta be honest. I gotta be honest with you. That's not. Let's acknowledge that that's not going to be a widespread problem, right?
True.
Therefore, it is not necessarily something that I've given that much thought to. If you have an organization, like if it seems to me, certainly there's companies in New York State that have other offices in other states, right? But if you have an office, if you're, I don't know, HBO, just to come up with a company, and HBO has their their main office here, but they have an office in Connecticut and they have an office in LA or something. It's that if you work in LA, you're going to be employed in LA, you're going to live in LA, etc. If you're employed in Chicago, whatever. So you would not be eligible, and the part of them that is here in New York, it would work in that regard. It would probably work like It's like it works right now. They probably have, like they sometimes have made in with employees in different parts of of the country have made deals with different companies in different states to get the better deal that they can for their employees in that part if they're providing healthcare at all. So, but a company that is based in New York that then kind of spreads over, there I would have to kind of it's a very specific issue, and I have one I haven't given that much thought to.
And I guess the other question is, do you see kind of like a California effect where, say, for example, cars, given the amount of cars that they produce, or even technology, where the standards that are established in California become kind of the de facto standard for the nation because of what they are producing? And I'd say obviously
I
New
hope,
York,
yeah,
New York,
I definitely this is part of the issue here is I want to make this so the way that it worked in Canada did not have a national single payer system all at once. It started in Saskatchewan, which is one of the provinces. So it needed to be demonstrated that it needed proof of concept, sort of so to speak. And eventually it became like within 10 years, I believe it became a national health program, not like the one in UK, but like something that covers everybody in the country. But my goal certainly is to make this a model for the rest of the country. And by the way, I am in conversations. These are very early. This is very early, but we are, as I stated earlier, I have a group of legislators that are from different parts of the country that are that have introduced pieces of legislation to have single payer in their state, or studying it, or looking at it, etc. So there's a bunch of us. I think we might have 15 states right now in the group. And there have been some early conversations. It's just like, what are the technical aspects of, say, for example, let's say that we get a system up and running like this in New York. Could we potentially then partner up with Jersey and Pennsylvania and Connecticut, or just Jersey or Pennsylvania or Connecticut, and then have cross-state systems where we would like be like that is something that could potentially happen before the feds get involved. We could do that across state lines. So it's and I'm talking about some of the things that might potentially happen down the line, but I absolutely want to create a model for the rest of the country. And I think that we have that obligation. I talk about that all the time. The state of New York, not only do we have the opportunity to do it because the size of our state, the population of our state, the tax base of our state, but the obligation to demonstrate to the rest of the country that it can be freaking done.
thank you so much. Any other questions?
Yeah, I've got a couple. Senator, I don't know if you can see me. It's David Gelman. I don't
Eventually
know
it's
how-
gonna, there you go. See
Okay.
did that? See what it did? It kind of like all of a sudden go like, it just opened it
Yeah,
up.
yeah.
Like, there
I've
it
got
is.
my own window now.
Exactly.
Yeah, I mean, this is going to be fundamentally different. Instead of having companies that are profit driven, as they should be profit driven. The focus would move to service delivery and the
patient
costs
welfare.
associated.
Patient welfare.
Patient welfare, and the state, who has an obligation to residents, would be primarily that board deciding on patient welfare. But to be clear on a couple of things, so there would be no copays and no deductibles.
Correct.
Okay. And one quick question: the $55 billion savings that Rand suggested, is that New York State alone?
That's New York State alone. So I
Wow.
would do two things quickly on that. First, something else that Flavia is going to send you for those nerds in the room, and I know there's a few in there. I will send you the Rand Corporation study that happened a couple of years ago. Now, granted, it's a couple of years old, but it takes a deep dive into the bill, and it actually gives you the pros and the cons of it. And it says this is why it would save that much money. And you could see this is not some crazy left-wing, nutbag. It's the Rand Corporation, and they show you all their math. So you can kind of take a deep dive on it. And I should tell you that although they're late, and I'm not happy about it because they told me that we're going to get it to me before the end of the year, they're going to get it to me before the end of January. There's been a group of academics and economists that have produced an analysis that is current. That should have come out before. They were doing like peer review and stuff at the end of last year, so it should have been in my hands before the end of the year, but it won't. It wasn't, but it will be in my hands like imminently that we will also provide you so you can see kind of where the savings would come from. But yes, that is just the state of New York.
Okay, and how many Senate co-sponsors do you have at this point?
Right now I have 32, but
Okay.
we just sent
Half.
that is correct. That is half. I just sent a letter to my colleagues to ask them to sign on and to ask more of them to sign on. And I will be doing some work in the next couple of weeks to get more people on the bill. So I am, as I said, I'm like gearing up. This is a year in which there's going to be some movement on this. I'm going to, if it's the last damn thing I do, there's going to be some movement on it.
Okay, and I know your peer list, but who's your peer in the assembly carrying this?
My peer in the assembly is Amy Paulin, who is the chair of the Assembly Health Committee. And Amy, what I will tell you is that there was a lot of work that she was doing the last couple of years. One of a very important bill to her and a very big bill was medical aid in dying, which she had been working on for like 6 or 7 years, and she finally got it over the finish line last year. So now that she has had, that was a big legislative burden that she was carrying. Now that she doesn't have that, she's going to engage much more in this bill. We just had a great meeting on Monday to talk just about that. So she's the chair of the Health Committee, the Assembly, and the sponsor over there.
Okay, thank you.
Thank you.
Absolutely.
So, thank you, Senator Rivera, for, I guess the only other, well, thank you for a very deep dive into, this very important topic. And we appreciate you taking the time out,
Anytime,
to
folks.
talk to us about it. Definitely looking forward to hearing more about not only this topic, but I think we desire to pick your brain on a number of other things. So we look forward to seeing you, in the future as well. And again, looking forward to some of that information regarding the progress of this.
Yep. I definitely look forward to it. And I thank you because again, as I said, these types of conversations are going to be necessary. We want to give people the notion that this is out there, that there is a bill here, that there is a potential progress that we can get if we build enough momentum. And I'm certainly going to be building on that. And if you have, so Flavia will send you the text of the bill, so you can have that as well for those folks that might not know how to access it online. We'll just get that to you. We'll also get you the RAND study. And as soon as I have this new one which reminds me, Flavia, I got to get on the phone with these people. We're going like, come on, I want this these damn numbers. We'll get that to you as well. And anytime that you have any questions or anything, I'm more than willing and happy to come back.
Thank you so much.
All right, folks. Thank you for having me.
One quick question, Flavia, are you still on the call?
Yes,
She
I'm
is
here.
indeed.
When are we having that MTA council conversation?
Jack Connors, has he reached out to you?
No,
Okay, so then
I've left
tomorrow.
several messages.
So then tomorrow we will be.
All right, tomorrow morning before 11, please.
All right.
Thank you.
Got it.
Sorry.
All right, folks. Thank you again. Have a great night. Thank you for the invitation. Be well.
Thank you. Thank you.
Thank
All right. Excellent. With that being said, I think the next order of business is the chair's report. We've had a number of great meetings. I think last meeting we had a great opportunity from a number of members of the community to discuss the substance abuse crisis, as well as some big topic regarding harm reduction by way of the fentanyl test strips, and it was a pretty informative session there. Nothing else particularly new. I think the big topic that we also talked about a little bit was the thinking about budget priorities and the ongoing discussion regarding a vice chair. Which also comes into the topic of unfinished business. We do need a vice chair. Obviously, I think one of the thoughts is if we can certainly consider dividing some of the tasks and responsibilities, and so that the lift wouldn't be so significant. I know all of us are busy, but that is important, because obviously by the end of the day, I still have to notify them that we don't have one. And I would hate to have somebody be voluntold, but that being said, I think I did speak with Barbara Kale as well, from the Aging Committee, who would certainly love to collaborate with us and have this conversation. Her biggest concern though is that that meeting is at 4 p.m. Because most of the older folk tend not to stay up that late. So, but at some point we will certainly, in the near future, certainly look to at least sit in on some of the meetings or find something at a mutual time that might be well, maybe even have a meeting on a non-Wednesday, maybe like a Saturday.
When do they usually meet?
They meet 4:30. I think it's before budget.
Oh,
When is it? Or no, before youth. I think so. It's the third. Oh, no, sorry. Thursday.
Oh, I can check the
Thursday.
calendar.
Thursday
I
to
can-
Thursday.
I can frequently make reports.
Second Thursday. So
That's,
that's
I'll check the calendar and let you know.
I will follow up. I know some from the previous meetings when we were talking about some of the domestic violence resources. And so I will try to see if I can at least probe a little bit. So I apologize on that. The minutes the was there, but I did a lot. But I will get some more details. I'll try to get at least a little bit more details on the Home Plus, the Safe Horizon, and see if the status of that victim advocate. I think the last time I spoke with the 50th precinct, they were in orientation. Hopefully we can get a full name for them. I think I also got in touch with Jalen, our old/new member of the board and the staff, and she is our liaison. And I think one of the topics is not only getting some of this data that we collect, but to get that in print and then maybe even work on getting that information packet for members of the community, and even having some of this data on the website as well.
Yeah, I was gonna ask that. Is there a space on the website for us to post community information? I mean, it's similar to the list I
Right.
put together on drugstores.
Yeah.
We could easily expand on that. It's
The website, and even I think they post things with topics of importance even on the Facebook page, and so I think that could be a topic that when we do get some of these items, I think work with Jalen to get that posted for the community to have access to. Like I said, information we're not necessarily. I think the big challenge obviously is a question of what are we advocating. But I do think that for the cases of
well, you wouldn't have to. I mean,
it's
I wasn't thinking of advocating anything, but just to
it's information.
to put names, addresses,
Absolutely.
websites of whatever. I mean, if physicians or practitioners in the community want to advertise on it,
Right.
we could conceive it,
absolutely.
right?
So that's coming up, and I think having her available as a liaison will be really, really helpful. That circumstance.
And the Riverdale Press has I think it still has a section of advertisements for professionals, including healthcare. We could conceivably get a line in there for more information about what's available in the community. It's like here,
That is an
kind of
idea.
thing,
That is
right?
an
I
idea.
hadn't thought about that till just now, but that's something to think about. I can talk to Farah about that.
Right.
Or already.
And I think that's that. I think I would also try to double back with Mosaic. So I haven't heard back from them to see if they have. They would be willing to come in and speak as well. Moving forward, let's see. I think just rediscussing the fiscal year 28 budget priorities. I think last time we talked in part about some of the topics we were concerned about. Obviously, the domestic violence, intimate partner violence, harm reduction as a whole. And I think if we get an opportunity to see what the priorities we had from 2027, although I think the push, if I recall correctly, was I think thrust a little bit more on the domestic violence aspect and see if we can, or in intimate partner violence. And see if we can kind of make sure that that's kind of our key point, and then with a few more solid things that we would like to.
Were they supposed to give us more information? The students who were on?
They were supposed to, and I don't recall getting anything.
Might be worth following up to make sure they didn't reach out to the office, they
Right.
just got lost in the shuffle.
Right.
I mean, advocate like more money for test strips seems like something we could ask for.
Right.
I don't know. Well, Homer.
Great. The unfinished business, again, as stated, the unfinished open position of vice chair.
If you need to put me down on paper, you can, but we've had this discussion.
We've had this covered.
No, I mean, I'd make the same offer. I don't know whether Julie would let me as a.
You would
As a rookie.
acknowledging that, I've learned, and you know better.
Honestly, my position is that I'm going to term out. I don't think it's this year. I think it's next year. And so at that point, I would rather have someone gain this experience as I've been a chair for a while. I've been to exec, I've wrote resolutions and such. So I'm happy I can help, but if somebody wants that experience, because I think in the next 2 years, half the board is terming out, at least.
Well, yeah, pretty much happening. Well, it depends on your calendar, but it's either 27 or 28.
Yeah, between those 2 years, I think
Right.
more than half the
But,
board.
but that's for the people who've been around for 10 years. I mean, about a third or half the board is still under 10 years.
Yeah, I just, again,
Yep.
we're
No,
gonna,
it's a good
we're
point.
gonna have
It's
a
a good
knowledge
point.
loss, and while
Yep.
I'm gonna be around, it's
Now,
not like
that's
I'm
my
moving to
main complaint
Siberia.
with term limits is the loss of intellectual.
We can talk about this after I've got.
Then we can talk about the
I-
Einstein and Strom Thurmond on the other side. But
But I mean, again, I don't mind doing this of taking the votes and, making sure,
Or even rotate, even rotating some elements. I think
another idea might be to even split some of the responsibility, and so like,
right, cause we can have 2 vice chairs now, didn't that
I
pass?
believe you can have one vice chair. I think it'll look great, look on your CV.
Yeah.
But again, I'm not gonna press the matter immediately, but it does behoove me to mention it, and like I said, if anyone is interested in even, I guess, trying it, I guess you could try that too. New business, any other matters?
Can I make a comment?
Yes, Madam
Hello?
Chair.
Hi. No, I was first, Happy New Year to everybody. I just wanted to ask, I'm not visually seeing anybody, but I heard someone say, I don't know if Julie wouldn't mind, was that Steve as
Yeah,
a vice
that was-
chair?
Yeah.
Are you
that
a
was me,
committee
Julie.
member? Are you a
Yes,
committee member? Then that's not an issue then, if you're a committee member.
okay, the reason I posed the question is whether you would let a rookie assume the position.
Yes, most definitely, because you'll be learning while you have the people there. The
Okay.
reason, the 2 things that you may be like mixing is that for the new people, the first year, I had asked that if you could just join 2 committees so that you could learn the committees and not stretch out, because in the beginning it is a lot. That was the only restrictions that I had asked for. As a vice chair, me personally, I think it would be great as a new person because you have the people experience. You have Julia, who's been a chair. You have the doctor, who's a chair. That would be perfect, in my
Rabbi
opinion.
Kaplan.
Rabbi, you're surrounded by chairs, so it would be perfect if you were the vice chair.
If Julia agrees to be my mentor, I will.
I am
So-
happy to do that.
So it sounds like we have a nomination for vice chair in the
Nice,
name
very nice.
of Stephen Matthews.
So moved.
Those in favor? Those opposed? The ayes have it. Congratulations, Mr. Matthews, you are vice chair. All right, I don't have to read.
Yes, good evening. My name is Maria Teresa. I met you at the at the meeting last year. I would like to say hi. My name is Maria Teresa Wallace. I go by she and her. The reason why I decided to be involved in this particular committee because I wanted to talk about a project I am doing, and I was wondering if you could give me the time and the space to talk about the project that I started out with the Silver Engagement. I'm part of the Silver Engagement. I'm an ambassador. Um, and I would like to talk about this project I have. It's called the Buddy System. Um, and when I say the word the Buddy System, is for people that were um, street homeless, formerly homeless people, people with lived experience that went through the shelter system, but they need somebody to help them out, like as far as an apartment, because they may have been street homeless and this to be their first time getting a place. So the person would show them around the neighborhood, making sure that things are being
So,
done for
Maria?
them. Yes.
Yeah, Maria. So I think we would love to hear about it, but I would like to formally add it on to I think potentially for maybe next meeting, and if you have any other material, we can kind of get that together and I'd love to have a formal presentation about this topic, and do you have any additional material?
Uh, yes, I will be working on that. Is it possible I could do it like in March, if that's okay with you?
I think let's see. I think the only March I think would be fine. I think because I think it's April is the only time that we don't have officially scheduled meeting time at this moment. But we can I would love to tentatively schedule you for March, and we'd love to have you on board for that meeting. And if you have any materials, we'd love to have a formal.
Okay, no problem. Hello? 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 Nope. Hello? Okay, let me leave.
S3425 is available on the New York State Senate website. You can download the PDF, it's 28 pages, and the assembly version of the bill is A1466. I believe, hold on.
Julie, if you can hear us, can you give us a shout?
Oh, so we're live.
If anyone can hear us, please acknowledge.
Anybody out there?
They're still on mute.
All right, so if the recording is
Oh,
going,
Can you unmute them?
Well,
Can
it looks like these aren't working.
oh yeah, one to turn it's like.
Yeah.
Again, I didn't.
Hi, Julia. Can you hear me now?
I can hear you. Can you hear us?
Another gentleman was on the line when I guess you guys went offline for a while. Someone else was online. You couldn't hear him.
Yes.
Question Maria again.
I was gonna say,
Hi,
Marie,
good evening. Yeah, for
Is
some
that
reason
your
I do.
email?
I don't know if it was my Wi-Fi or.
it was probably.
It was us.
It must have been us.
Okay.
So what I would say is if you should probably, if you reach out to the board office, we can get a dialogue going, because I don't want to ask you to give your email because these are public meetings. But if you reach out to the board office and let them know that you've discussed with us and we're planning for tentatively for March, we can get that ball rolling so that we can set up that formal presentation for you.
Thank you. Is it March, what, the second week in March?
Second, yeah, it should be the second, yeah, so I did the second Wednesday in March, so I believe that should be the 11th.
Okay. All right, I'll definitely make sure because I need some time to get the materials and everything. I appreciate that.
Correct, perfect. Yeah, we'd love to hear from you, and we will make sure when we start planning the meeting that we'll have you on for March 11th. Okay, any other new business? All right, so next meeting will be February 11th, 2026. That should give you plenty of time to get ready for your significant others for Valentine's Day. With that being said,
Motion to adjourn.
motion to adjourn the meeting.
Second.
Okay, all those in favor?
Good night, Gracie.
Good night, Grace. All right, good night, everyone. Have a pleasant evening.
Yes, good night.
Good night,
Thank you.
everybody.
Good night, everybody.
Congratulations, Steve.
Good night.
Did you
All
ever
right.
watch Burns and Allen?
All right,
Um,
thank
so
you.